So we're going to go into the brain, neurocranial disorders. I have them broken up into a couple of different sections: traumatic head injury, brain bleeds, inflammatory brain disorders, and then there's a couple that didn't really fit anywhere else. Cerebral aneurysm could go in with brain bleeds because that's what they do cause. Brain tumors are kind of their own thing. But what we're going to do is you're going to see, I set this up a little differently than some of my normal lectures. I have all of the cues for all of them, and then we talk about all of the interventions that go with all of them, and then we do specific stuff. So we kind of talk about general brain stuff, then we talk about specific cues, and then we talk about general interventions, and then we talk about specific interventions. So they're all kind of broken up a little bit, but most neurocranial disorders all have the same interventions. So I wanted to point out and spend most of our time on the similar interventions for everything. Why aren't you letting me go forward? I'm sharing my screen. Go forward. There we go. All right. So again, we just came out of hopefully the anatomy lecture, if you were there. Make sure you understand the ICP, intracranial pressures, and cerebral perfusion pressures, the normal and the dangerous values. I do want you to especially know the dangerous values of them, okay? And just to review, that is an ICP greater than 20 is bad, and a CPP less than 60 are very bad. Those are our danger values. Those are the things that we're like, things are not going well in the brain in those dangerous values. Also to remember that injured brain tissue swells, okay? You clock yourself with a hammer on the finger, that finger's going to swell up. If you damage brain tissue in any way, it's going to swell up. And when that brain tissue is swelling, it will increase the ICP. Blood anywhere outside of a blood vessel, so bleeding onto the brain tissue, is irritating and causes brain swelling. So a brain bleed, not only do we have blood kind of on the surface of the brain that's not nourishing the brain, it's just actually causing more swelling. So brain bleeds actually take up space because the blood is sitting outside the blood vessels, taking up space, and the brain is swelling around that blood area. So we get double the trouble there. Blood on the brain is irritating. All cranial disorders, no matter whether it's traumatic or stroke related or inflammatory related, cause a change in the neuroexam and are at risk for increased intracranial pressure. And any change in a neurostatus, any deterioration of the neuroexam, you don't need to let a doc know that things are getting better, but you do need to let a doc know if the neuroexam is getting worse, because you're the gateway to the head CT or to the MRI or to further diagnosis. Your eyes and your assessment are the clues that more intervention is needed. So neuro is all about the assessment. If you hate assessment, do not become a neuro nurse. So for any cranial disorder, whether it's a traumatic injury, a bleed, an inflammatory process, a tumor, having any kind of cranial process is going to cause a headache. Okay, headache is a generic. It doesn't really tell us much. The level of pain, the amount of pain, the degree of the headache doesn't really, we certainly would want to get that information, but it doesn't specifically point us to where we need to go. Headache is a general thing. Photophobia, meaning that you don't like light, is also a general symptom of having a cranial disorder of any kind. Nausea, vomiting does go, again, nausea, vomiting is not indicative of anything other than that there's a problem somewhere. It could be anything. Restless, irritability, confusion. Whenever you have a headache, I get restless and irritable when I get a headache, so it doesn't mean that I'm completely unoriented. But these are all generic things that basically you have something going on in your head. You have headache, you don't like light, you're not feeling that well, you're irritable, you're restless, and you could have any form of abnormal basic neuroassessment, any form of an abnormal Glasgow Coma Scale, any abnormal cranial nerve exam, okay? So none of those, just having Abnormal neuroassessment isn't necessarily a worsening cue. What we're calling worsening cues is increased intracranial pressure. So you can have a brain tumor, you can have a small bleed, you can have a seizure, you can have things that will cause you, you can have a migraine that can cause you to have existing cues of a cranial disorder, but it starts to get worrisome when we're having increased intracranial pressure. So the signs of increasing intracranial pressure are a worsening or a decrease in your Glasgow Coma Scale. So if you were awake and now you're not as responsive, you want to call me lethargic because I'm hard to wake up. Let's put a number to that description. And so most neuro patients of any kind will get a Glasgow Coma Scale. If you're anything other than awake, and if you can't answer questions, you're going to get a Glasgow Coma Scale, and we're going to watch that Glasgow Coma Scale for a decrease. The other thing that will show you that you're having increased intracranial pressure besides a worsening Glasgow Coma Scale is going to be any worsening of your assessment exam. So maybe I came in with aphasia. I can't really find my words very well, which happens all the time to me anyway. So I kind of live in a baseline cranial disorder. I am constantly irritable and constantly confused. I constantly have trouble finding words. I just call myself, I tell my kids, you're never going to know if I have a stroke. You're never going to have a clue because my brain moves too fast anyway. I constantly live with, a nursing student. I mean, basically people live with, the existing cues of a cranial disorder because depression's a cranial disorder, anxiety's a cranial disorder, being stressed is a cranial disorder. I mean, really, any cranial disorder will cause these symptoms. So they're not really, the generic ones, they could mean anything, but I still have I'm usually pretty oriented to person, place, time, and situation, usually. Time, a little iffy. But anyway, my basic neuroassessment usually is intact. My Glasgow Coma Scale is usually a 15, unless I'm slurring my words or something. Cranial nerve exams usually intact. I can move everything, I can do everything, I can hear everything, feel everything. So anyway, if any of that started to get worse, then that would be concerning if my Glasgow Coma still started to drop. Or Cushing's triad, which I like to think is the complete opposite of shock. Cushing's triad is an increased blood pressure and a decreased heart rate and a decreased respiratory rate. They have nothing to do with Cushing's disease. It's just this doctor was pretty prolific. Dr. Cushing's found a lot of stuff. But anyway, Cushing's triad is that as your brain pressure goes up, the signals kind of get sent out wrong, and it actually is a warning sign. What are these also? Increased blood pressure, decreased heart rate, decreased respiratory rate, the opposite of shock. Increased intracranial pressure is the exact opposite of any kind of shock, because shock will give you a decreased blood pressure, increased heart rate, increased respiratory rate. Cushing's triad is the opposite. But if you start noticing that your patient is trending up, why do you think they're trending up on their blood pressure? What do you think the body's trying to do underneath all of this when it's trying to save itself? It's trying to increase its cerebral perfusion pressure. So yes, it's trying to get perfusion to itself. And it's like, dude, I've got control over vasoconstriction, vasodilation and I don't want to die. So I'm going to cause vasoconstriction. I'm going to up my MAP and I'm going to get perfusion to myself. So the brain is trying to do that. Decreased heart rate, decreased respiratory rate is due to pressure on the cerebellum where our autonomic nervous functions are working. And that is actually sending out an opposite signal saying slow the heart rate down, decrease the heart rate, respiratory rate. You'd think it would, if it was trying to save itself, you'd think it would be increasing its heart rate and increasing its respiratory rate because that will get more oxygen and more perfusion. But unfortunately, some of this increased pressure is disrupting the function of the cerebellum. So anyway, why and all the pathophysiology behind it, just know Cushing's triad is the opposite of shock with an increased blood pressure, decreased heart rate, and decreased respiratory rate. very late. So this is as things are increased intracranial pressure. We're either increasing the size of the brain tissue and we're pushing out CSF or blood. We have an increased amount of blood, swelling of brain tissue. We've got things shifting around in the skull there. I don't know if you can see this picture here when I blow it up. Let me blow up, and I think it's on my next slide as well. But do you see this little brain here in the bottom corner? Here, this little brain is under a lot of pressure from increased blood. The brain underneath it is swelling, but you can see it's actually physically pushing the brain. And the last exit, the only exit for the brain, is at the base of the skull where the entrance to the spinal cord. So when brain runs out of room and it's already pushed out all the CSF it can, it's already tried to get as best perfusion as it can, then actually brain tissue will herniate into the spinal cord. It's the only hole, and if the pressure gets high enough, that's where the brain will go. The only exit out is through the spinal cord. So if we end up having brain tissue displaced into the spinal cord area, what it does is it compresses your carotid arteries going up into the brain, because now we're putting pressure on those arteries that are coming up through the base of the spinal cord into the brain, and we end up cutting off blood flow to the brain. It's like compartment syndrome of the brain here. And so basically herniation does mean that brain tissue has herniated into the spinal cord, and the problem with herniation is it cuts off blood flow to the brain. If you're seeing brain death, you have fixed and dilated pupils, a GCS less than 5, and hypothermia. The lowest GCS you can get is 3. So a GCS less than 5 is definitely pathologic, and hypothermia because you're not regulating your temperature anymore. So we don't want anything to get to herniation. Herniation is actual death. So we don't want anything. So all of our interventions are in between finding an increased intracranial pressure and making sure we don't get to herniation. We'll do anything possible to keep the patient from herniating, because that means they will die. I'm just going to say that localized cues are again going to depend on the specific area that is swelling, and so you may see increased intracranial symptoms along with deficits motor and sensory wise, and cranial nerve deficits. I'm not going to outline them because they could be anything depending on where your exam is. The generalized increased ICP, if your brain is under a great deal of pressure, you will see a decrease in, thank you, went on autosave. I don't know how to shut off autosave mode on this thing. It just, it cuts out and goes into autosave and shuts off. And so I don't know how to do that. Thank you for calling me to it. So generalized ICP is going to give you Cushing's triad and a decrease in your overall Glasgow Coma scale. Those are really the only general overall signs that we're looking for. The big ones are going to be changes in your neuro exam. So your localized cues. So you will find neuro nurses hand off to each other at bedside the neuro exam, because the neuro exam is so important on a neuro unit, and that changes in the neuro exam are so significant that there's no one sign or symptom for increased ICP other than Cushing's triad and a decreased GCS. There's no specific sign or symptom. It's all decreasing neuro exam. So they will do a full neuro exam at bedside report, so that you know how you're starting your day and you know if anything changes. The localized exam is your most sensitive cue, and I can't give you a list for it. You have to make sure that you're doing the neuro exam with your previous nurse, so you know exactly where they started out and you know if things are getting worse. Does that make sense to everybody? I wish I could give you a slide that tells you anything other than Cushing's triad and lower GCS that you're having increased intracranial pressure, but it's going to depend on your neuro exam, and any worsening of your neuro exam could be considered a sign of increased swelling. I do have a little slide here on what herniation looks like, and this is the blown up of that picture. This is where the brain is actually herniating into the spinal cord, and you can see here that the more brain that herniates, the more compression you're going to get of these two vital arteries here. And if those two vital arteries get cut off, and you end up with brain tissue all here, then we have cut off blood flow to the brain, and that is considered actual death. If the brain cells die after 15 minutes of no oxygen, just like your heart will die and stop pumping, your brain will stop managing bodily functions. And so that is considered brain death, is full herniation to the point where there is no blood flow to the brain. And I don't mean not a little dribble, I mean none. So you can see on this angiogram here, this is normal blood flow here. This is the circle of Willis, and this is everything headed off to around the brain. And here is the circle of Willis, and nothing. Nothing after that. Complete emptiness of blood flow around the brain, and that is significant because this brain has been anoxic. Anoxic brain tissue will lyse and swell, and it will not get better. If someone has been declared brain dead by cerebral angiogram or apnea or anything that basically is saying we have no longer any functions of our brain stem and our brain, if you're declared brain dead, it is considered dead, just as good as cardiac dead. So I do have a slide there on brain death, which is hopefully something that we will prevent by doing our interventions. But if a patient does herniate into the spinal cord and that is not fixed within 15 minutes, they can proceed on to brain death. Brain death is defined by every hospital has a confirmatory test for brain death. It varies between hospitals, but usually the confirmatory test is going to a cerebral angiogram and seeing no blood flow. If you are completely apneic, if they take you off the ventilator and there is no respiratory function whatsoever, that is also considered brain death. There's a couple of different, you'll have to read your hospital's policy and procedure on declaring brain death. Every hospital has one, and they will follow that procedure to declare someone brain dead. Cardiac dead is very easy to declare. There's no more heartbeat. Brain death, you want to be sure that the swelling has caused irreversible and brain damage. So the patient is declared legally dead if they go through the brain death process. Even though the heart may be beating and the ventilator is providing oxygen, this legal death means that if we removed any artificial means of support, you would die naturally. Because the only thing providing you with any ventilation and any oxygenation to the rest of the body is the ventilator. So if you are declared brain dead, you are legally considered as dead as if you're cardiac dead, and the only reason that you can prolong ventilator support is for organ donation. You're also not supposed to ask families for organ donation. There's a lot of controversy amongst families that people do believe that the hospital staff are not taking best care of their loved ones in order to harvest organs. And so they do believe that, if the hospital staff approaches them about organ donation, it's because hospital staff had something to do with wanting the organs. And so they remove hospital staff from the discussion of organ donation. So it's done by a third party, which is the organ procurement organization and here for Arizona, it's Donor Network of Arizona. You call them when they have referral criteria, and they take that discussion out of your hands. You don't need to worry about it. If the family brings up organ donation, or if they meet the criteria, that basically their GCS is less than 5, they're already on a mechanical ventilator, and they've lost 2 or more of their brainstem reflexes, or if you feel that the patient would be a good organ donor, or if you want to discuss it with somebody. You could call Donor Network at any time, and they will discuss whether the patient meets criteria, doesn't meet criteria, and if they do meet criteria and want to have a discussion with organ donation, they assist the hospital in going through their brain death policy, and they assist with talking to the family. So you don't have to take that on your own head. In fact, you're discouraged from doing so because they want to remove the hospitals. Hospitals are providing best care to these neuro patients that could be reaching brain death, but they want to remove the stigma of hospitals doing something to someone to get organs. That's not something that hospitals do, but it's still a myth out there, and so we want to remove that, and we let a third party take care of organ donation conversations. Does anyone have any questions on that? I'm probably not going to test on it, but it's something that a lot of people want to talk about or discuss, so I do put it in here, that the only way to become brain dead is to herniate into your spinal cord and cut off blood flow to your brain. And the brain swells to the point that it cannot even do its autonomic functions. Autonomic functions meaning breathing, heart rate, temperature control. If the brain cannot function itself and do any autonomic functions, then you are brain dead. This does not mean persistent vegetative state, where if they remove the ventilator or decrease the ventilator support, the patient still breathes on its own. If the patient's breathing on their own, has a cough, has a gag, does anything, I mean, that may not be that they ever mentate again, but they are not brain dead. You have to have an absence of respirations and no brain function at all to be considered brain dead. Does that make sense? So that's that. Please feel free, any questions, let me know if you have any questions or concerns about that. Probably, again, no test questions on it, but that is what we are trying to avoid, and what we do are interventions to avoid. We don't want patients becoming brain dead. So I have the 3 different traumatic head injuries here on a chart. Concussion, contusion, diffuse axonal injury, and basilar skull fractures. Now, you can have any kind of skull fracture at all, but the treatment will not be any different for it. We do have some specific treatments for basilar skull fractures, which are fractures at the base of our skull. You can have a fracture anywhere in your skull. Skull fractures will lead to concussions or contusions. If you've been hit hard enough to fracture your skull bone, you probably have a concussion or a contusion under there, and we will follow concussion contusions. You can also have, if you've got a blow hard enough to fracture your skull, you probably have a bleed under there, and we'll take care of you as a head bleed. Not many people are just taken care of for skull fractures, but there are a couple of considerations for base of the skull fractures, so we put that separate. Concussion contusion is basically a knock so hard that you have reset the electrical activity in your brain. It's kind of like you have cardioverted or defibrillated your brain. Remember, brain is all working on electrical activity, chemical activity. And so if you jar your brain hard enough, all those neurotransmitters and all those neurons and all those electrical signals kind of stop for a minute, and then everything gets reset. So a concussion just means that your electrical activity has gotten jarred for a moment. Concussions can have no tissue damage at all. It's just a stunning of the transmissions for a few minutes, and then everything will get reset and restarted. A contusion is a physical bruise on the brain, or there's been some kind of a localized tissue injury to the brain tissue. Both ways, either a concussion or contusion can have no loss of consciousness or a very brief loss of consciousness that is regained within a period of time. There's usually no increased intracranial pressure cues, no worsening ones. You certainly would have a headache, photophobia, nausea, vomiting. You may have a decrease in your cranial nerve exam or some change, but no increased intracranial, no worsening cues. Okay. And it usually heals without intervention in 1 to 2 weeks. So concussion contusions, we usually, what's the treatment for it? Monitor their neuros and look for any decrease in the neuro exam, because that moves you into worsening, increased intracranial pressure category. And so usually concussions, contusions do not head into worsening symptoms, but we will be on the lookout in the neuro exam. So if you've ever had anyone that got a hit on the head and you had to stay awake with them for the night afterwards and wake them up every few hours, what you're doing is you were doing a neuro exam. You weren't even a nurse yet. If you've ever taken care of anybody that got hit real hard in the head, or if your kids are at football or soccer practice and got smacked around a little bit, concussion or contusion, we still have to keep people up. The reason to keep people up is to do a neuro exam. If you, after a couple of hours, they haven't had any decreasing neuro status, then they're not going to. They don't ask for 24 hours of neuro exams anymore. They usually will just watch you for about 4 to 8 hours afterwards. Because if you're not going to bleed from your concussion, contusion injury within 4 to 8 hours, you're not going to bleed. So, yeah, they don't ask for us to monitor you and follow you around and wake you up for 24 full hours. If you get knocked in the head at noon and you haven't had any symptoms by 8 o'clock, you're not going to have any worsening symptoms. Any bleed or any swelling that's going to happen after a concussion or contusion is going to happen in the first 4 to 8 hours afterwards. So they generally will just ask you to do it for about 12 hours afterwards. So that's concussion, contusion. Really, there's usually no other signs or symptoms with it. The little picture on the end there with the arrows pointing to it are pointing to a contusion. You can just see there's a little bit of white stuff. What we're looking for is bright white on a CT scan is usually blood. The dark areas on the CT scan, just not that you're going to be reading CT scans, these dark areas are the ventricles with CSF. And these lighter white areas, that's just some blood in there. So when we're looking at a CT scan, we look for a couple of different things. We look for, oops, I didn't mean to draw on that. We look for these ventricles. The ventricles look like a little butterfly. And we should be seeing all the ventricles there on a CT scan. And we should be seeing symmetry. So we kind of look for the butterfly and we look for symmetry there, and then we look for any bright white spots. So that's really what we're looking for in a CT scan, and I'll show you some abnormal CT scans in a minute. But we're just looking for symmetry, and we are looking for midline, and we're looking for symmetry on that midline. So that's what we are looking for when we look at CT scans. We, meaning nursing, that's about as much as I can read off of a CT scan. Diffuse axonal injury, this is not in order of severity by any stretch of the imagination, because diffuse axonal injury is a very severe head injury. This one is actually where the neurons have actually been broken, and it's usually due to what they call a coup contra coup injury, where you've been thrown forward and then backward very rapidly. That shearing and that forward-backward motion actually break the neurons. And of course, we learned back in Block 3 that broken nerve cells can't transmit. So if you break a bunch of nerve cells in your brain, there's not going to be a lot of functioning. But these broken nerve cells cause quite a bit of diffuse swelling and edema, and they usually have very bad worsening ICPQs, usually very high intracranial pressures, usually a low GCS. And then basilar skull fractures are fractures at the base of the skull, and it causes bleeding. These CSF, these ventricles, are at the base of our skull, and so when you fracture the base of your skull, then you could have more of a risk of bleeding and CSF leaks, because we have a lot of blood flow, and the ventricles at the bottom of our skull and the bottom of our brain, and so a fracture to the bottom of our skull can lead to bleeding and CSF leaks. Very high risk of infection, and you will see these 3 signs are very indicative before you even go to a CT that you have a basilar skull fracture. If you have bleeding behind your ear, which is battle sign, raccoon eyes, which is exactly what you think, it's bleeding around the eyes, and a CSF leak from the nose or the ear. That's what rhinorrhea means, drainage from the nose, and otorrhea means draining from the ears. So you have clear, possibly blood-tinged drainage from your nose or your ears. It does not mean you have sinus congestion. The CSF, that could be CSF leak if you have a runny nose along with battle sign or raccoon's eyes. That could be a sign of a basilar skull fracture. You test the drainage. And a quick test is looking for halo sign, where you put some of the drainage on like a 2x2 or a 4x4 gauze, and it will create a halo. Oh, I keep thinking, I don't know if you can see on this picture here, the halo sign, but that is where it basically, CSF is the only thing that makes that halo sign, where you'll have the, you'll have the drainage. This is the actual drainage, and then it starts separating into concentric circles around it. So CSF does the halo sign. It also has glucose in it, so you can send off some of the drainage for a glucose test, and CSF will have glucose in it. So we'll talk about the interventions for those in a minute. I'm just talking about all the different cues that kind of show you a little bit different than just ICP. So if you have a concussion contusion, you won't have any signs or symptoms of it, really. You happen to see it on a CT scan, maybe, if there's any contusion. A concussion does not show up anywhere on any scans. That is symptomatic only. Oh, I had a knock on the head, and now I'm nauseous. Okay, well, you have a concussion. They'll just give you the diagnosis. There's no other real cues. Diffuse axonal injury, the cues are usually a very high ICP, intracranial pressure, and a low GCS. And then when they're on scans, they'll see diffuse swelling of the brain tissue. And basilar skull fracture will have those three: battle sign, raccoon's eyes, and a CSF leak. Brain hemorrhage, you can have bleeds anywhere in the brain. An epidural bleed is usually arterial because the arteries run in the epidural area. Subdurals are usually venous, and intraparenchymal or intracerebral, those could be any kind of vessel, arterial or venous, and those are usually located within the brain tissue itself, so they have a little bit different treatments. Arterial bleeds happen quickly. Imagine an arterial bleeder spurting in the brain. It's only going to stop when it has filled the space or started pushing out brain tissue. Arterial blood declines rapidly. So a severe headache, the worst headache anyone's ever had, a 40 out of 10, and then a rapid decline in your neurostatus. It takes minutes to hours for an epidural to cause neuro changes. And it's usually unilateral deep weaknesses, unilateral cranial nerve and motor changes. Venous bleeds or subdural bleeds. These are venous bleeders. They're oozers. It depends on the patient, but can occur slowly over days to weeks. It's a dull, throbbing, constant headache, but you do have a steadily declining neurostatus over days to weeks. So if your child had a concussion and the next day you notice them getting more and more confused, and then the day after that more and more confused, you would be asked to come back in because they could have a subdural bleed after that contusion. It will happen. I said it will probably happen if it was arterial or something that we're going to see. It would happen pretty quickly afterwards. Subdurals can happen over days to weeks. And they usually get caught before they cause major problems to the brain. They also have unilateral symptoms as well. And then bleeds within the brain tissue itself, subarachnoids, intracerebrals, interparenchymals, they're all kind of intra-brain tissue. They will have localized deficits based on where the bleed in the brain is. Again, I'll bring up my mother-in-law who had a cerebellar hemorrhagic stroke due to hypertension. Her only symptom was dizziness, but that dizziness did not go away. And then when they did the CT scan, they found the bleed in her cerebellum. So again, localized motor and sensory deficits within minutes to hours, depending on how big the bleed is. So again, are you going to be able to tell from the symptoms what kind of bleed it is? Not usually, unless it's an epidural bleed. you have to get a CT scan to really look and see where there's blood on it. And I think I have a couple pictures. This is just a bigger picture of that one. You can see that subarachnoids and subdurals cause a pooling of blood on top of the brain and end up pushing the brain away. And the intraparenchymals and intracerebrals, they're within the brain tissue themselves. Epidurals and subdurals can be evacuated. You can actually pull those blood clots, those blood bleeding out of the brain. Intracerebral and subarachnoid and intraparenchymals, you cannot go into, you'll end up causing more damage to the brain tissue trying to remove the blood, so we don't really remove the blood from those. But we'll talk about the interventions in a minute. Here's our plethora of bad CT scans. And you can see bright white is usually considered blood or skull on the CT scan. And if we're doing our little checks for symmetry, we can see here that we have symmetry. We kind of have symmetry there. There's our butterflies. But our butterflies are really kind of teeny tiny there. And actually what they start looking for is that, do we have symmetry from the midline? We do not. So we're supposed to be looking for symmetry, but symmetry should be midline. And here the midline has been shifted. There's no symmetry at the midline, so this is considered a shift. And it's due to this big glop of blood there, pushing the brain tissue out of the way. Here's our subdural, and again, you're not asked to read CT scans, but you can kind of see the subdural here. But the thing that as an ICU nurse, we go down and look at CT scans, we're looking for midline, and there's no symmetry on the midline. Whenever we have symmetry, we don't have symmetry, or we've lost the midline, we have severe problems there going on with the brain. It's called a shift, and that's what they're really looking for on the CT scans. Here, this is a... where do you think this bleed is happening here? Where's this star pattern? Where is that? What are we seeing that bleeding around? Any thoughts? That's your circle of Willis that is now bleeding. And so that is a large, large bleed and is actually going to end up cutting off blood flow to the brain cell. That's a circle of Willis. That's a pretty bad injury right there. And this, I'm not sure if that's a tumor or what's going on with that thing. Again, I'm not really sure what all these, I'm not good at reading CTs beyond symmetry and midline on symmetry. But anyway, there's a couple of off CT scans for you. And again, this is stuff that these cues you should be able to distinguish. Again, epidural, subdural, I would like you to know what kind of bleeding is most common, but I'm not going to expect you. I mean, a patient that has been walking, talking to you, and then all of a sudden passes out is more likely to have an epidural bleed than a subdural bleed. A patient that's been progressively getting confused and having neuro changes over days to weeks is more likely to have a subdural bleed. That's really as much detail in the bleeds as I'd want you to go into. The inflammatory brain disorders, I put 4 of them up there. Bacterial and fungal meningitis, they have the same, almost the same symptoms. Meningitis is an inflammation of the meninges around the brain. So you can see these guys are all swollen in here. This is basically the lining around the brain themselves. So it is pushing its infection right on top of the brain. It's infection of the linings of the brain. So if you have infection on top of the brain, then this tissue all in here starts to swell, because now we're going to get an immune response there to that area. And then if you have bacteria in the meninges, you could very easily have bacteria in your brain as well. So can cause a great deal of global swelling, because if your entire covering is infected, it's kind of like peritonitis. If your entire membrane is infected, then all the organs around it are affected. All the organs within that membrane are affected. So meningitis is inflammation of the meninges. We need to figure out the cause of it. Both of them cause inflammation of the meninges. Bacterial is usually due to a respiratory bacteria called meningococcus. It is found in your lungs. It is highly contagious. It is spread with airborne droplets, just like COVID is. So it's a respiratory bacteria, and it is spread similar to it's a respiratory virus. So it is put on respiratory isolation. The bacterial meningitis has a high fever because it's a bacteria, and Kernig's and Brudinsky's and nuchal rigidity are the three symptoms of meningitis, either bacterial or viral or fungal. Any meningitis is going to have Kernig's, Brudinsky's, and nuchal rigidity. And I have a slide, and the next slide is about those three signs. Nuchal rigidity just means neck stiffness. So right now I have nuchal rigidity because my neck muscles are tight as can be, but I do not have Kernig's or Brudinsky's sign. I don't also have a fever, so I don't have meningitis. But anyone that comes in with neck stiffness and a fever is going to get a Kernig's and Brudinsky's sign test. Bacterial meningitis also has a skin rash with it as well. To definitively diagnose meningitis, you need a CSF analysis. They need to pull some CSF and look at it because CSF is circulating around the meninges, so CSF will carry with it whatever you're infected with it. So they will do a CSF analysis for any person coming in with nuchal rigidity, Kernig's, and Brudinsky's sign. Viral usually has a lower fever. Again, virals have lower fevers. It is not the respiratory bacteria, so it's not contagious. It also has Kernig's, Brudinsky's, and nuchal rigidity, but no skin rash and usually a lower fever. Again, we're not going to go off of our cues to diagnose it. They'll do a lumbar puncture and get CSF analysis. And the CSF analysis on a bacterial meningitis will have very high pressures. Again, when they call this high spinal pressures is when they actually put the needle in. They have a measurement device, and they call those opening pressures when they actually puncture into the lumbar, into the arachnoid space to pull the CSF. They get a pressure reading, and because bacterial meningitis is so inflammatory, has much higher pressures, markedly high white blood cells, and a low glucose because the bacteria ate all the glucose in the CSF. They have a low glucose level, and the culture is positive for bacteria. And then when they pull out CSF from a viral patient, there's lower opening spinal pressures, only slightly increased white blood cells, not markedly increased. They have normal glucose findings, and the culture is negative for bacteria. Remember, cultures take like 24 to 72 hours to come back, so they will tentatively diagnose it based on the number of white blood cells and glucose in the CSF to determine whether you have meningitis or not. Encephalitis is an actual infection of the brain tissue, not the surrounding meninges, the actual tissue, and that is usually due to viral causes. And that will cause, if your brain tissue is swelling, you're going to have increased intracranial pressures. You will have a low-grade fever because a virus is causing it, but you will not have Kernig's, Brudinsky's, or nuchal rigidity with encephalitis. Excuse me, talking too much. And I put status epilepticus in here because I'm not sure if you talked about it in Block 2 when you talked about epilepsy and you talked about seizures, but it is inflammatory to have your brain firing nonstop as it does in a seizure, and that excessive seizure activity is very bad for the brain. It's called brain on fire for a reason. It causes a great amount of brain inflammation and can cause increased intracranial pressure if it is not stopped. So of all the status epilepticus stuff, I would want you to know the criteria for it, because if you meet criteria for status epilepticus, you can have increased intracranial pressure and brain inflammation from having a seizure that you can't get control of. Any tonic-clonic seizure lasting 5 minutes or longer is considered status epilepticus, but if you have a second seizure before recovering from the first, so you have a seizure that kind of puts you in that post-ictal phase, and then you have your second seizure without recovery, that can consider status epilepticus, or any seizures that are repeated of any kind, whether it's tonic-clonic or absence or any kind of seizures for more than 30 minutes or longer. And the reason we do that is because brain inflammation can cause a lot of other problems. And here's your Kernig's and Brudinsky's. This is basically that they show them on a kid, but I like putting the letters right here. Koenig sign is that basically you have the meningitis is irritating your spinal column, and so when they go to lift the leg, you cannot straighten the leg when your hip is flexed. It's super hamstring tightness is Koenig's sign. And I like to think of the K there as the kids laying down. When they lift the legs, you kind of make a K because you can't bring your leg all the way up there. So that's Koenig's sign. And Brudinsky's sign is that when you pick up the neck that is stiff, your knees bend. That's Brudinsky's sign. So I did put the B and the K there so that you can maybe keep them as separate. But as long as you recognize that if patients have Brudinsky's or Koenig's sign, they have some kind of meningitis. It is specific for meningitis. Just like Holman's sign is where if you push down with your foot, it causes pain. That is basically a DVT if you have Holman's sign. If you have Brudinsky's or Koenig's sign, you probably have meningitis. It just takes a CSF analysis to say which kind. So if someone comes in, and knuckle rigidity, again, is not specific, but knuckle rigidity combined with Brudinsky's sign. So I know my neck is as tight as can be because my neck muscles are always tight. But if I bend my neck forward, my knees don't bend up with it. So I do not have Brudinsky's sign. So knuckle rigidity is there, but you have to have probably one of the other signs along with it to be considered for a lumbar puncture. And that's just because you have irritation in the meninges and it's irritating your spinal column. So that is Koenig's and Brudinsky's sign. AV malformations is basically an aneurysm or malformed blood vessels in the brain that basically are usually asymptomatic. There really are no cues for it other than probably localized pain, headaches that don't go away, local changes in the neuro exam, possibly seizure disorder. Usually they will find these aneurysms or AV malformations on a workup for any seizures or headaches that you might have that don't go away. If you have seizures or you have headaches that don't go away, you'll probably get a CT or an MRI after you bother the doctor enough, and then they find these aneurysms and malformations. An aneurysm or malformation, the important thing to remember about it is the significant risk of bleed and if it ruptures. So you could probably tell what the interventions are going to be, but we're not at interventions just yet. Intracranial tumors are tumors in the brain. Again, there really isn't much of a cue for it other than focal neurodeficits, possibly a seizure disorder, and we would know those focal neurodeficits. Basically, okay, all of a sudden the patient doesn't have control of one leg anymore. That could be a tumor or bleed or anything in the motor cortex. All of a sudden the patient is having trouble doing math, not just because they're in nursing school and they're stressed out, but they used to be able to do 2 + 2 and they can't anymore. Probably in the area involved in calculation. I can't remember. It's behind the motor sensory cortex. I don't remember which one it is. But anyway, your local neuro symptoms, again, will buy you a CT or an MRI to diagnose further. So we finished our cues. We're looking into the key assessments. Again, the key assessments on any neuro patient with any consideration of neuro damage is the cranial nerve exam and the basic neuro exam. We're going to keep watching those exams for any kind of worsening. If you're concerned about increased intracranial pressure, we'll be observing for Cushing's triad. So you're going to look at the blood pressure, heart rate, respiration. If you see your blood pressure trending up and your heart rate trending down and your respiratory rate trending down, that could be a sign of Cushing's triad, which means you have increased intracranial pressure. And we will also keep an eye on our mean arterial pressure to ensure that the mean arterial pressure is greater than 60. And if we are seeing Cushing's triad with it, we're probably going to want that mean arterial pressure to be even 70 or 80 to overcome whatever intracranial pressure we are having. We can monitor intracranial pressure, but again, it's highly invasive, and they will probably only do it if you are having a worsening cranial nerve exam or neuro exam. You'd have to have a pretty pretty big neuro injury to get invasive ICP monitoring, because it is something that they put into the brain. You don't want to do that lightly. We can usually watch the increased intracranial pressure by the neuro exam. So again, not good news if you don't like neuro exams. Don't be a neuro nurse, because they're really relying on you. So we're going to do the interventions, and this is for all cranial disorders. So I don't care if it's a bleed, if it's a basilar skull fracture, if it's a tumor. These interventions will work for any neuro exam, okay? And these are our base interventions for any cranial nerve deficit, no matter what kind it is. We're going to continue to monitor that neuro assessment. That's the number one intervention, is frequent neuro assessment. The second one is maintain oxygenation to the brain. If the brain has had any injury, swelling, damage to it whatsoever, we're going to make sure that they have good oxygen. This may be that your oxygen saturation may be 92%. We're going to go ahead and just bump it up anyway. The brain eats 20% of our total oxygen. It's a high consumer of oxygen, and we want to provide it with the best oxygen. So a lot of neuro patients are on oxygen, just like most cardiac patients are on oxygen. Why not? Let's give oxygen for healing. There's a very low threshold for starting an oxygen on a neuro patient. Go ahead and start oxygen. We want it going. We want to prevent any ischemia to the brain. Keeping pulmonary hygiene going, avoiding atelectasis pneumonia. We don't want respiratory infections. They all compromise our oxygenation, and we need all the oxygen going up to the brain that we can. Maintain perfusion. Keep that mean arterial pressure. Again, we want it. That mean arterial pressure of 60 means that you don't have any intracranial pressure. We're assuming that a patient with a cranial swelling of some kind has some kind of elevated intracranial pressure. It may be 8, it may be 12, it may be 15, we may not know. So keeping that mean arterial pressure up above 70 is a goal for most neuro patients. We want that cerebral perfusion pressure greater than 60, and unless we have an ICP monitor, we don't know exactly what our intracranial pressure is. So we just assume that it is high, and we want to maintain a mean arterial pressure that will provide perfusion, even if our intracranial pressure is high. So remember, a mean arterial pressure of 80 will provide perfusion even if your ICP is in the danger zone. So a higher MAP is usually requested. We don't want it going above 100. 100 is very high and could cause cerebral blood vessel explosions, which is not going to help our bleed or our status epilepticus or our inflammatory thing. We want to keep our mean arterial pressure really in that range so that we're providing good blood flow, but not too much. Okay. One of the good ways to maintain cerebral perfusion is maintaining your neck in the neutral position, meaning right upright, not bent to the right, not bent to the left. If we bend our neck to the right or the left, or put your chin to your chest, then we are decreasing, basically flow of the carotids or the jugular veins. We're decreasing flow up to the brain, and we're decreasing flow out of the brain if we have our neck off to one side or chin to chest. So you want to maintain your neck in neutral position, almost like it has a C-collar on it, and that's to provide your carotid arteries no restriction. Does that make sense? So make sure your neck is in neutral position, not because they have an injury in their neck, but because we want those blood flow unrestricted. Maintain cerebral perfusion, keep your MAP up, and keep your neck straight. Neuro patients always have their neck flopped to one side, so you always see people have pillows and towels and things rolled up and stuffed up next to the neck to keep the neck in that neutral position so we don't restrict blood flow. Of course, we're going to want to decrease the intracranial pressure. And how do we do that? We do that in numerous ways. So this is important. Could you put a C-collar on as prevention? They could probably maybe do a soft C-collar if they want one. But again, you don't want someone tightening the C-collar too much and putting, pressure on the arteries or veins that way either. So a soft collar, possibly, but generally we usually support with pillows or rolled up towels on either side of the head, just to keep that neck from flopping forward or to the side. You don't need to go as invasive as a C-collar. Those are usually pretty uncomfortable. But maybe a soft one, if you're really having trouble, that could be an intervention you could ask for. But just make sure you don't tighten it too much around the neck. Yeah, no, not usually C-collars, but you can. So the main interventions are decreasing intracranial pressure. So again, keeping the neck in neutral position helps venous drainage, helps keep blood out of the brain, keeps blood draining from the brain, keeping the head of the bed elevated greater than 30 degrees at all time. I don't see any neuro patients that are laying flat unless they have a lumbar puncture or a lumbar drain. Otherwise, head of the bed up. Does that make sense? Remember we said you want to lay flat after a lumbar puncture because we're draining fluid out of the lumbar space, and that's going to cause a headache to sit upright. The only exclusion to this, so I'm going to write that there, only exclusion to the head of the bed being up is lumbar puncture or lumbar drain. If we are actively pulling CSF out of the lumbar space, then that is when you would lay flat. Okay, the only exclusion to that, decreasing intracranial pressure, we are pulling CSF out, and so we've decreased the pressure. You could lay flat during the recovery time. If you're having a lumbar drain where they're constantly pulling CSF, then you may lay flat. Does that make sense? So head of the bed upright greater than 30 degrees to get venous drainage from the brain, but you can lay flat if they have they're recovering from a lumbar puncture or if they have a lumbar drain in that is draining CSF. Okay? Otherwise, head of the bed up, neuro patients are sitting upright unless they've been poked in the for a lumbar drain. If that is not enough, and you're seeing neuro changes, and you're having a worsening GCS, and you're having worsening neuro exam, then we are having an increased ICP because you're showing your worsening cues, a worsening exam. Maybe your Cushing's triad is getting more, your hypertension, your high blood pressure is going up, your heart rate's going down. Maybe, so your Cushing's triad's getting excessive, your cranial nerve exam is worsening, and the GCS is going down. Then we're going to need to get more aggressive. The next, so least invasive, sitting them upright, neck in neutral position. Then we'll go to an osmotic diuretic. Those are things like mannitol. Mannitol is a special diuretic just for the brain. They can give mannitol anytime. It is a diuretic, but it is a super diuretic. And what it's going to do is you're going to pee a ton, and we actually are physically dehydrating the brain tissue. And normally that's not a good thing. I'm not saying it's not going to cause problems on the brain, but the brain tissue is so swollen, we want to get the fluid out of the brain. And that's what mannitol and hypertonic saline do, is they pull fluid out of the tissues, and mannitol, you will pee it out. Hypertonic saline, you'll beef up your circulation, but you will pull it from the tissues. Mannitol is the primary one. I don't see hypertonic saline too often on neuro patients, but if it is combined with a low sodium, they will use hypertonic saline. But mannitol is really your key intervention to dehydrate the brain. You will see patients with brain swelling on mannitol, PRN, for increased ICP or for worsening exams. Sometimes they're on it every 6 hours or so. Yes, you will become massively dehydrated, but that's what we're doing to save space in the brain, because remember, we are trying to avoid herniation. If the brain tissue continues to swell and we're getting close to herniation, then it would be better to dehydrate that brain and shrink it than it would be to kill it. So mannitol is something they will do to dehydrate the brain and shrink it so that it fits into the skull space. The other thing we can do, so maybe we can't prevent, or they're not handling the mannitol. They can't handle the dehydration anymore. Their blood pressure's too low. We can't keep their blood pressure up. We can't keep their MAP up. So they don't want to do mannitol any longer. Then we're going to have to physically go, and we can't, we're not going to remove brain tissue. We're not going to remove blood flow. But we can remove CSF. We don't really need it. It's a cushion for the brain. If the patient's in severe distress or increasing ICP, the next most invasive is to remove the cerebral spinal fluid. And that is where they put the drain into the ventricles and actually drain out CSF as it's being made. Like basically the patient will not have CSF anymore. Do you think they'll have a headache? Well, heck yeah, but they also have increased intracranial pressure and a worsening neuroexam, so their headache is probably the bottom of our list right now. If they have not responded to the osmotic diuretic, then they are probably so brain swollen that they're not really working on the Glasgow Coma Scale. They're not awake, they're not alert, they're not conscious. We're going to be removing cerebrospinal fluid in order to maintain an ICP. And if that doesn't work, where we have had the ventricles are completely collapsed, you can see on this patient, let me see if I could blow up this picture down here at the bottom again. I'm going to blow up and show you this bottom picture. This is a patient pre and post decompressive craniotomy. So you can see here, I can see a couple of things have happened. You've got a huge bleed right here. This is all blood. Let's look at our midline. There is no symmetry on midline there. In fact, I'm not even seeing the butterfly. We're really, the ventricles are getting compressed here, and you can see how the whole brain is kind of shifted over to the side, and basically it's already compressing the ventricles. At this point, what they did was they went in and they ended up removing the skull. This is actually brain tissue right here. That's the edge of your brain tissue. They have evacuated all that blood. They took that blood off the top of the brain, and the brain is now swelling out. These are actually, this right here is meninges. This is, they've taken the skull off here, and this is meninges. And they're allowing the brain to, this is probably not the best color for drawing on black. They're allowing the brain to swell out this way. So they've given it an out other than the spinal cord. And so it's better to take off a piece of your skull and let your brain swell outwards than it is to herniate and die. So that is the probably the most invasive thing that you will do to see them. Oop, I didn't mean to close out my whole PowerPoint. That's probably the most invasive thing that they will do to save a brain. Is the decompressive craniotomy. So they might try to remove CSF for a while, but if the brain is swelling so quick and so fast that it is looking like herniation, they may go in and take a piece of the skull. And that is to allow the brain to swell out of an area other than the spinal cord. It basically relieves pressure on the brain. So that is an option for patients. And so it's basically least invasive to most invasive. They will try to maintain neutral neck, head a bed up. If that's not working, they add the osmotic diuretic. When the osmotic diuretic does not work, they'll put in a drain to remove cerebrospinal fluid. And then if that's not working, they will go in and remove a piece of the skull to allow the brain to expand. Does that make sense there? So you may see people, they may decide to go in if the brain injury is big enough and they know the brain is going to swell and there's nothing they're going to be able to do, they may go straight to a decompressive craniotomy. And so I don't know if you've worked with any patients. If you go to Barrows and work with any of the patients there, you may see patients that have post-brain injury and they have that piece of the skull removed and they're wearing a helmet afterwards. Because once the skull is removed, you have no protection on your brain. What they usually do is they take the piece of skull out and put it in your abdomen so that it remains nourished and doesn't die, because the skull is a living bone. It needs nourishment, it needs blood flow, and so they store it in your abdomen, or sometimes they take it and freeze it somewhere, but they do store your skull for putting it back on later. But basically they do remove a piece of the skull. and that is better than dying of brain death, if they can get you in there to do that. And then what we're trying to do, your dad had a drain after the accident, but not the craniectomy. So the drain then was maintaining his inner cerebral pressure at an adequate level. The drain usually does, if we can get all the CSF, then we've got room for the brain and the blood to go in there. So I don't know, if you've had experience with all of this stuff, this might be making sense to you, hopefully, why they did what they did. The other thing we're going to do is we're going to let the brain rest. So we are maintaining oxygen, we're maintaining perfusion, we are decreasing the intracranial pressure, and we're letting the brain rest. Complete brain rest the best we can. Decreasing stimulation, this works for any, even if you don't have an increased intracranial pressure. Decreased stimulation if you have a migraine, if you have a concussion, if you have any kind of skull fracture, any kind of damage to the brain, it's going to hurt. And so decreasing stimulation, they also call it concussion rest, where you're not allowed to eat. You're not allowed to read. You're not supposed to watch a lot of screen time. That's to decrease your brain firing. And I had to go through this with my daughter. She just had a concussion, and I had to tell her, I'm like, well, you've got to sit. She's like, I'm bored. And I'm like, I don't care that you're bored. Your brain has to rest. If you're stimulating your brain, you're causing firing, and it's going to cause your worsening headache. So dark, quiet environment. This includes the hospital. Neuro patients are usually neuro units are usually left kind of dark, kind of quiet. Reduced visitors. Cluster your patient care. You don't want to be having the lights on and in the room all day, all night. The brain will continue firing. If it's getting stimulated, it's firing, and that can cause more swelling in the brain. So we want to decrease stimulation, keep the fever down, decrease the metabolism for the brain. Pain control is going to be non-narcotic. No matter how crazy your patient is acting and how out of their neuro exam they are, you're not going to get narcotics for a brain disorder patient. No narcotics, because that will dull the neuro exam. It does change your neuro exam, and so you're not going to get narcotics from any neuro doc at all. They hate narcotics and will not give them to you. No narcotics, no benzos. They are usually managing pain with Tylenol, muscle relaxants, if we do need to sedate them with things that are reversed quickly, and so that we can do our neuro exams. But you don't get narcotics for neuro patients. So if you have a test question and it's asking you about pain control and you pick the narcotic, no. So if you like to give out narcotics, don't go work in a neuro unit, because you won't get them. It does dull the neuro exam, and the neuro exam is too important. Antimicrobial therapy, again, we don't want any kind of infection, so most patients with any cranial disorder will be treating infection soon, looking for signs, symptoms of infection, and treating those infections before they become inflammation. If the ICP is increasing, if you're having increased ICP or worsening symptoms, then they want to prevent any seizures, any brain firing. We may need to, sometimes the patients do get put into a coma with barbiturates and paralytics. And again, that's just to basically shut down the brain from firing at all. Will it affect our neuro exam? Yes, it is. They will do some sort of neural monitoring if you have paralyzed the patient, in order to be able, you will either be measuring the intracranial pressure directly, or you'll be monitoring brainwave activity if you sedate a patient, because you've lost your neuro exam as soon as you paralyze them. But it may be necessary to get the brain to shut down enough to stop swelling. Again, the more it's being asked to do, it's like the heart. It can't stop. So we ask a lot of the heart when it's damaged, and we sometimes have to support it mechanically. There's nothing to support the brain mechanically, so we are going to be, sometimes we do have to say, all right, enough is enough. We need to shut you down so that you don't swell anymore. And they will put a patient in a medical coma to make the brain stop working, because working is causing swelling. And if that does happen, then you are usually, we do need to monitor, so I'm just going to write that off to the side. You lose the neuro exam. And so we will monitor ICP directly or monitor brain waves. And I'm not going to teach you that because it's just too much. They can also put the patient into moderate hypothermia, not the deep, dark, severe hypothermia, but moderate hypothermia like they would after cardiac arrest, because again, that will slow down your heart rate, your respirations, your breathing, and your brain activity. So there are two options but both of them do require sedation, and so you will need to have ICP monitoring or some monitoring of your brain waves, because if you are sedating a patient or putting them in a coma or induced hypothermia to save the brain, we'll have to monitor their brain function some other way. And then, of course, maintain blood glucose. I don't mean high, but the brain needs glucose for its activities. So we're going to keep that blood glucose right around 100 to 140, not too high, not too low, and maintain that glucose. So if they need to be eating, then keeping that up. This is not the time to starve a brain. Any starving the brain's going to cause more damage and swelling. So maintain the glucose. So those are our main, for any cerebral disorder: maintain perfusion, maintain oxygenation, decrease the intracranial pressure, decrease the brain workload, and maintain your glucose. Okay, 5 things that we do for every single neuro patient. Even a concussed patient, you will be doing those things. Make sure they got enough oxygen, make sure that they've got optimal brain healing, keep everything quiet, dark. If you see worsening things, then you need to go and get help. And that's really our keys for brain assessment. It all goes down to those 5 things. So now we have a couple of additional interventions. And again, I'm sorry, I know it's running late. I am recording all this. I'm going to finish up this lecture and then I'm going to let you go. But then I'm going to record the spinal lecture and post that in your module so that you have it for later on. Basilar skull fractures, again, if you have battle sign, raccoon's eyes, any CSF drainage, we do have a couple of specific things on top of everything you're doing, those 5 interventions from before. No NG tubes. Oral gastric is okay. You can put a tube down the oral to the gastric, but you're not going to put it... Does everybody see the picture up at the top there? This is why there's no NG tubes, because if you have a fracture at the base of your skull and we are shoving a tube up your nose, it can get through the fracture and into the brain. So no NG tubes. You could Google NG tube in the brain and find tons of CT scans where the NG tube has ended up in the brain. So no NG tubes, nothing nasally. You can do an oral gastric tube if you have any raccoon's eyes, battle sign, CSF leak, any drainage, clear drainage after a head injury from your nose or your ears. If you have an order for an NG tube, do not put it in nasally. You have to go in orally. Because you have a sign of a basilar skull fracture and you don't want NG tube in the brain. You don't want to be the nurse that did that or the doc that did that. So don't put an NG tube in, even if you have an order for it. Ask if you can do it oral gastric because you have signs of basilar skull fracture. We don't want a lot of sneezing or blowing of nose. We let the drainage kind of run out. Put the gauze, again, this is CSF, it's not sinus drainage. So we don't want to be increasing sneezing or blowing the nose, increasing pressure, and then we're just blowing more CSF out. So just tell them, yes, you have a basilar skull fracture. You may have a drainage from your nose. Just wipe it, blot it with gauze, and keep an eye on the headache level, because depending on their drainage, you would want to test the drainage to make sure it is CSF. You can send it off to the lab for glucose content, check it for halo sign, but make sure that any patient that has a CSF leak is getting adequate hydration. Because we make CSF on our own, just like we make urine, just like we make secretions. We're going to make CSF at a rate of 2 to 10 milliliters an hour, but if they are draining 20 milliliters an hour, they're going to end up in a CSF deficit and a severe headache. So make sure they get adequate hydration so they're producing CSF to replace the leak, and certainly let the doc know if the leak is getting worse or that they're using more gauzes. You'd want to keep an eye and somehow quantify that CSF leak if you can. Just so that you have an idea of how much is leaking out. Again, we'll remake it, but if your patient's having a worsening headache after a basilar skull fracture and their drainage is increasing, that could be a sign of increasing CSF drainage, and may need some intervention from the doc. They can do what they call blood patches, where they can patch a CSF leak, so there are interventions for it. So just let the patient... Thank you. Sorry. I apologize. Obviously, I'm talking too long. My microphone's telling me to take a break. But I want to just get through these real quick and let you go. So try to quantify your CSF drainage, maybe, a gauze every 4 hours or something like that. But try to quantify it so that you have an idea of how much CSF is being drained to see if it needs to be an intervention. And we don't, again, want anything that's going to increase our intracranial pressure. Sneezing, coughing, gagging, vomiting, all that stuff's going to make your CSF leak worse, because when you do all those things, you transiently increase your intracranial pressure. Think about a sneeze, how much pressure goes on in your head if you have a sneeze. If you're gagging and coughing and throwing up, that's a lot of pressure in your head. And while the pressure in your head is high, CSF will be leaking out. So all those things increase your CSF leakage, so we want to minimize them if we can. Brain bleed, really, you're just going to be doing those 5 interventions. But if the bleed is on top of the brain, like this one is here, this bleed is I wanted to draw. It's not letting me draw. This bleed you can see right here is sitting on top of the brain. They may be able to go in and evacuate that out if it's causing a midline shift, which is what we see on CT scan. This is a shift off of midline. And so if you have an epidural or a subdural that's sitting on top of the brain and causing a shift, they may go in and physically remove that blood clot in surgery. But otherwise, you're just going to be maintaining your 5 interventions for cranial disorders. Meningitis, the big king on meningitis is they're supposed to go into respiratory isolation until the lumbar puncture has disproved bacterial, because we assume bacterial because it's the worst one. If you're coming in with Kernids, Brudinski's, nuchal rigidity, then they're going to go on respiratory isolation until a CSF analysis is done and read. Then once it's confirmed viral, you can take them off isolation. If it's confirmed bacterial, they'll continue respiratory isolation. That's the big keys on meningitis. Did my sound go away again? Or is that an old message? Am I there? Okay, good. Thank you. Just want to make sure. I saw a message pop up. For status epilepticus, again, just a couple of specific interventions. Again, just like treating a seizure is benzodiazepines and convulsants. We'll definitely be doing those for status. Status epilepticus will probably have continuous EEG monitoring. And this is where they will coat their brain with electrodes and actually be monitoring the patient for about 24 hours during and after that status, measuring their brain waves to see what's going on with that patient. If they cannot control the seizures with benzos and anticonvulsants, they may do the medically induced coma, which is the phenobarbital and paralytic coma. Because again, status epilepticus, a constantly firing brain, is going to become inflamed and swollen. So status epilepticus, those are our least invasive to most invasive IV benzos and anticonvulsants. A continuous EEG, not a 12 lead, not a heart EEG. An EEG is an electroencephalogram, which is basically a constant readout of brain waves. And if you've been at Barrows on the neuro units, they have their patients are all in the bed, and they put on a camera on them, and have a continuous monitoring of the EEG. And they will do that for any period of time and let the doc keep an eye on that brain. And then a medically induced coma if they can't get it under control. I just listed the benzos and anticonvulsants there just for your, in case, I say we're starting Keppra or something like that, it is a anticonvulsant. And cerebral angiogram, again, a cerebral aneurysm or AV malformation, we want to keep the blood pressure lower than usual. We want to maintain perfusion to the brain, but we don't want hypertension. Avoiding hypertension or high MAPS causes these things to break. It's already a fragile blood vessel. And so they want to control the blood pressure, hypertension control, the same as a aortic aneurysm. It's hypertension, a lower blood pressure, avoiding hypertension, but we still want to maintain, remember, our cerebral perfusion. We want to avoid any blood thinners, and then there's a couple of interventional approaches where they can go in. It is a interventional procedure, femoral procedure, and they will inject things into sclerose or clot off those aneurysms or malformations to prevent them from bleeding. If you find them, a lot of times the only time they find them is after they burst. So again, if you're having localized symptoms, they will go in and do a couple of interventions to clot off or fix those abnormalities so they don't bleed. And tumors, the thing I'm going to say about tumors is that surgical removal is the best way to remove them. It does involve removing some of the brain around them to get clean margins. And then radiation and chemo is a follow-up. But usually IV chemotherapy does not cross the blood-brain barrier as easily. So if the chemotherapy that is effective does not cross the blood-brain barrier from the IV route, they may go ahead and put chemotherapy directly into a ventricle and let that chemotherapy circulate around the CSF space. And that's done through a reservoir where they physically put a drain or a catheter into the ventricle there and have a port that they can inject chemotherapy through. So you may see something like that on a brain tumor patient, and that is for giving chemotherapy directly into the ventricle space. You will not be able to access that. Only a physician or advanced practice nurse would access that reservoir to give chemotherapy. Cranial surgery, again, very, very basic. This is not, you're not qualified to take care of brain surgery. Well, maybe you are, take care of brain surgery patients. But we do expect drainage devices after brain surgery. Sometimes they're just, they're subdural where they just drain. Again, most surgeries have drains associated with them afterwards. Brain surgery is no different. If it's not in a ventricle, it's not going to drain CSF, so you could have any variation of drainage devices in there, but what's important to find out is it in the ventricle or not? Because if it's in the ventricle, it would drain CSF. If it's not in the ventricle, it's just draining wound drainage. All your cranial disorder interventions are expected to be doing maintaining oxygenation, perfusion, doing a neuro assessment, decreasing ICP, and brain rest after brain surgery. Don't expect increase intracranial pressure, and so if we do see any of those things, then we'll have to go to the higher, notify the physician, go on to the higher interventions for decreasing ICP and maintaining brain rest. We don't expect a low blood pressure because, again, we need cerebral perfusion. We don't expect too high of a blood pressure because that could cause bleeding in a surgery that's been done on a brain, and we don't want hypoxia or infection. And then I just put this out again. We can do ICP monitoring that's not in a ventricle. Again, ICP monitoring has to be done in the brain. The kinds that will monitor ICP are the intraparenchymal, the epidural, and the subarachnoid. The only one that can drain is the intraventricular. All the other ones will just be for monitoring. They're usually called bolts of some kind, but they are just basically catheters that are inserted to an area of the brain that can read pressure. So it just depends on what the doc wants to put in. ICP monitors don't drain CSF. They just monitor, and they can be like, yeah, you got a really high ICP, but it's not going to be able to enable you to do anything about it. Just anytime you put something into the brain, watch out for infection, bleeding, or a CSF leak. And there is the only one, the external ventricular drain, is what can read an ICP and drain CSF. If we are draining CSF, you do need to watch that hourly to make sure that you're not draining off too much CSF. And again, I'm not going to teach you how to use a ventriculostomy, but I like to call it the Foley for the brain, and it is where we will drain CSF if our ICP gets above a certain limit. We set the doctor sets the height of the drain. The drain sits at a certain height above your earlobe, so above the base of the brain. And basically the brain has to overcome, if the brain pressure is higher than the level that the drain's at, you'll drain out CSF. We never want the drain to be below the level of the ear because we will be constantly draining CSF. You only want CSF to go out if the ICP is too high. So we kind of set the drainage, and I will set it up next week and let you see it. I do have an ICP. We can put an ICP drain out, and I can show you kind of what it looks like. But again, you're not going to have test questions on how it works or how to use it. It's just for funsies. But again, anytime we put anything into the brain, we are looking for any signs of infection, excessive CSF drainage, or bleeding. So we don't want to see any of those things, and we would notify. And then the VP shunt is probably the thing that you're most familiar with, or you're mostly going to see. This is a permanent ICP drain. This is it's a catheter in the ventricle that can drain CSF. And so there is a ventricular catheter sitting in the ventricles, and then there is a shunt valve which controls the ICP. And when the ICP gets to be a certain level, it lets CSF out. And on these patients, because it's permanent, it drains into your abdominal cavity. Most of them, that's ventriculoperitoneal is just where the CSF is draining into your peritoneal cavity, and then it'll get reabsorbed, and the fluid will be recirculated. So this is usually on patients that have had chronic CSF problems or have hydrocephalus. If they have constant increased intracranial pressure from too much CSF, then they can get a VP shunt placed, and that will continually drain CSF out of the ventricle. Or if you've had so much brain swelling that it cannot be maintained, and they're tired of, they don't want the external drainage device anymore, they may put in an internal drainage device. And it's very similar to the external drain, except that the control is not outside the body. The control is that shunt valve that is sitting on the outside, and therefore on the hand there is the size of the drain and the VP shunt. That shunt valve can be controlled. I've seen ones at Barrows that are magnetically controlled. They have a little dial on the shunt valve that tells a certain ICP, and the practitioner can go in with this magnet and turn the dial, so they can say any ICP greater than 15 will drain CSF. Any ICP greater than 10 will drain CSF. They can decide which ICP drains CSF. It's pretty cool. So a VP shunt is basically internal, and there shouldn't be any chance of infection because it's all internal, and the extra CSF is draining to your peritoneal space. So support for cranial disorders, a lot of mood disorders, thinking processing disorders, cognitive function fluctuations for even years after the cranial disorder. So support groups are available. Most patients do end up with family therapy and occupational therapy, support groups, rehab therapy. Anytime we've gone in and done some damage to the brain, you have to relearn old skills that you had. So that's really the teach and communicate around there. But make sure that families are understanding why you're doing what you're doing. They don't understand why you're limiting visitors. It's not to be mean, and well, now with COVID, they're limited anyway, but usually neuro units do limit visiting and visiting hours because it's part of your intervention for brain rest. So anyway, I think that is enough on neuro.